And thanks everyone for joining today. And I really appreciate the opportunity to share important information about American Indian health and how obviously that links so directly to the Montana Obstetrics and Maternal Support Program. So really appreciate the opportunity. So my name is Dr. Donald Warren. I'm Oglala Lakota, originally from Kyle, South Dakota on the Pine Ridge Indian Reservation. And I've worked in multiple areas in health over the years. I'm a family doctor, and I also have a master's degree in public health. And I've worked in academics as well as in primary care medicine. And I'm currently the co-director of the Center for Indigenous Health at Johns Hopkins Bloomberg School of Public Health. And I'm also the provost fellow in Indigenous health policy. So I've been teaching courses on American Indian health policy for about 20 years. 20 years ago, I was on faculty at Arizona State University at the Sandra Day O'Connor College of Law, and I started teaching American Indian health law and policy at that time. So that was in the law school, so I was not a lawyer, but I played one at work for about 4 years while I was on faculty at ASU. Today, we'll look at American Indian health policy for the majority of our discussion, but then we'll also look at the impact of poverty on American Indian health. And these two discussions link together for a number of reasons. One, when we look at maternal and child health, we tend to see worse outcomes in impoverished populations, but also from a policy perspective, the role of Medicaid and Medicaid expansion are just so vitally important to maternal health as well as maternal and child health. So I think these are quite relevant discussions when we're looking at the topic areas. We'll go ahead and get started with American Indian health policy. And let's go ahead and start with demographics. And we know based on the 2020 census, there's actually over 9 million people who self-identify as American Indian or American Indian and other race or ethnicities. And if we look at those who self-identify as American Indian only, it's over 3.7 million American Indians and Alaska Natives, according to the 2020 census. Of those numbers, the majority live in urban settings. So the majority of American Indians and Alaska Natives do not live on reservations. Most live in cities. So another thing to keep in mind, even though there's over 9 million people who self-identify as American Indian and Alaska Native, the Indian Health Service user population is about 2.4 million. So what that tells us is that the majority of American Indians are not using the Indian Health Service. So it's an important thing to keep in mind when we look at data sets and when we look at IHS data that is reflective of the population who uses IHS services, but is not reflective of the entirety of the American Indian and Alaska Native population. So actually, the majority of self-identified American Indians and Alaska Natives do not use the IHS. As an example, I live in Grand Forks, North Dakota currently, and there are no Indian Health Service facilities here. So if I wanted to use IHS, it'd be an hour-and-a-half drive. And I also have insurance, so I don't need to use IHS. I can go to the private sector. So people like me are not included in the IHS database. So just important to keep that in mind, that we cannot assume that the outcomes in the IHS data are reflective of all American Indians. So we look at our user population, so an active chart in the IHS system within the last 3 years, and we see that there's 2.4 million users of the IHS. The annual appropriation for IHS is about $6 billion. So as we will see, the Indian Health Service is actually terribly underfunded relative to other federally funded health systems. And we serve over 570 federally recognized American Indian and Alaska Native tribes. So here's some more data from the US Census, and the population of American Indians and Alaska Natives is now again at 9.7 million, and that is nearly 3% of the US population. And on the section to the left here, you can see there are several states that have at least 4% American Indian or Alaska Native population. So that includes Washington, Oregon, Wyoming, Arizona, North Dakota, where I am, Montana, where most of you are, South Dakota, where I am from originally, then New Mexico, Oklahoma, and Alaska. So there are 10 states that have at least 4% American Indian and Alaska Native population. And Montana, as a percentage of the population, is the 5th most populous state for the American Indian or Alaska Native population. So you can see on the map, we're primarily in the western half of the United States. And of course, that's because colonization started in the East. So many of the states in the East have far less than 2% American Indian or Alaska Native population. But in Montana, obviously, and the Dakotas, very significant numbers of Indigenous people in these states. I really like this map looking at the state of Montana and looking at the tribal nations and the reservations. And very pleased that this map does include the Little Shell Chippewa tribe, which is one of the more recently federally recognized tribes in the state of Montana. So wonderful to see that. But as we kind of look around the state, to the far west is the Flathead Reservation. On the northern border with Canada is Blackfeet. As I mentioned, Little Shell, which is located in Great Falls. Then Rocky Boy Reservation, Fort Belknap, Fort Peck, Northern Cheyenne, and Crow Reservations. So 8 reservations in the state of Montana. And unfortunately, as we know, some of the worst health disparities, particularly when it comes to maternal health outcomes and child health outcomes. So very important things to keep in mind as we address American Indian health policy. So we have to keep in mind that IHS is the primary federal agency that provides health services to the American Indian and Alaska Native population. But our system is very diverse. So it's called the ITU system. I is Indian Health Service, where we have federally delivered health services. Those are authorized in the federal government through the Snyder Act. So the Snyder Act was in 1921, and that's the law that allows Congress to appropriate funding annually for Indian Health Service. T is the Tribal 638 programs. We'll talk in more detail what that actually means, but the Public Law 93-638 is the Indian Self-Determination and Education Assistance Act of 1975. And that's what established the tribal programs. The U of ITU is the Urban Indian Health Centers, and that is authorized through the Indian Healthcare Improvement Act, specifically Title V of the Indian Healthcare Improvement Act. And in the state of Montana, you have a wonderful network of urban Indian health centers. So in Montana, you have each of the 3 components of the Indian health system. You have IHS facilities, tribally operated facilities, and urban Indian health centers. And we'll talk a little bit about what that means in terms of a policy perspective and services delivery. One thing that's important to keep in mind is that American Indians are very unique in the United States in that we are the only population born with a legal right to health services, and that's based on treaties. And the graphic here on the left is right from the Indian Health Service website, and it shows the legal basis for federal services to American Indians and Alaska Natives. And it goes all the way back to the US Constitution. The Commerce Clause of the US Constitution is Article 1, Section 8. And the Commerce Clause states that Congress shall regulate commerce with the foreign nations and the Indian tribes. So going all the way back to the US Constitution, tribal nations are put on equal par with foreign nations. So from a federal Indian law perspective, that's seen as the legal basis for federal recognition of tribal sovereignty. Of course, tribes have considered themselves sovereign long before there was a US Constitution, but there's a legal precedence for federal recognition of tribal sovereignty going all the way back to the Constitution. I'd mentioned the Snyder Act of 1921. That's what allowed for Congress to appropriate annual funding for the Indian Health Program. Transfer Act in 1954 moved the Indian Health Program from the BIA in the Department of Interior to what is now the Department of Health and Human Services. So Indian Health Service in its current form has been in place since 1955. And then looking at Indian Self-Determination and Education Assistance Act of 1975, we'll talk in more detail about that. That's the law that established the tribal programs of the ITU system. Then the Indian Healthcare Improvement Act of 1976 established the urban Indian health programs. Now, on the right, this is actually one example of the many hundreds of treaties that were signed between the federal government and the tribal nations. This particular example is the treaty between the Potawatomi Nation and the US government in 1846. And I know it's in very fine print, but at the bottom, it states that the tribe of Indians giving assurance hereby of fidelity and friendship to the government and people of the United States, and the United States giving at the same time promise of all proper care and parental protection. And that's common language in many of our treaties, is promise of all proper care and protection. But I would ask the question, have American Indians received all proper care from the Indian Health Service? And of course, no, unfortunately, we have not. So if we look at a treaty as essentially a contract, underfunding of the Indian Health Service means that the US government is in breach of contract and is not really upholding the treaty responsibilities to provide health services. So as a starting point in any American Indian health policy discussion, we have to recognize that American Indians are born with a legal treaty right to health services. Unfortunately, the federal government just has not lived up to those responsibilities to fully fund the health program. So just looking at some recent data on annual funding for various federal health programs, you can see that Medicare is funded at over $13,000 per recipient per year. Veterans Health Administration is funded at over $10,000 per qualifying veteran. Medicaid is over $8,000 per year. And look at IHS, about $4,000 per person per year. Now, of all these populations, they each have a legal right to health services, but IHS is just terribly underfunded. And that has a huge impact on health outcomes, including maternal health, child health, and health disparities across the board. So looking at our system, it's a very unique system with a very unique history. The provision of health services to American Indians and Alaska Natives grew out of that special government-to-government relationship between the federal government and the now 574 American Indian tribes. So that's another thing that's unique about tribes, is that we are sovereign nations within the US government. So when tribes work with the federal government, it's a government-to-government relationship. So it's very different than if we look at, for example, African-American populations in the South or Hispanic populations in the Southwest. They are distinct populations, but they do not have a government-to-government relationship that is unique to the indigenous peoples of the United States. This is also right from the IHS website, and it states that the Indian Health Service, or IHS, is the principal federal healthcare provider and health advocate for Indian people. And I would agree that they are the principal federal healthcare provider, either direct services or through funding programs like the tribal programs. But in truth, the principal advocates really need to be the tribes, because if you work for the IHS, you're a federal employee, and federal employees cannot lobby, right? They have to be very careful in terms of the types of advocacy that they do. So in truth, we have to have this partnership and this relationship between tribes and the federal government to blend advocacy with the provision of health services. The goal of the IHS is to assure that comprehensive, culturally acceptable personal and public health services are available and accessible to American Indian and Alaska Native people. And what a wonderful goal, but we're nowhere near achieving that goal, unfortunately. Comprehensive, culturally acceptable personal and public health services. And because of underfunding of the Indian Health Service, the vast majority of the resources are spent on medical care. And even though the IHS is a part of the United States Public Health Service, we do relatively little public health because of lack of resources. So that's an important starting point to really understand American Indian health policy, is that we have a legal right to medical and public health services, treaty right to these services. However, the IHS has been terribly underfunded by Congress, really for generations. And as a result, we see terrible health disparities. So when we think about the tribal programs, that really started in the 1970s under President Nixon. So this was the beginning of the self-determination era of federal Indian policy. And it was President Nixon's message to Congress in 1970, so now 52 years ago. He actually called for self-determination without termination and restoration of tribal sovereignty. So prior to this, really the 50s through 1970, the federal policy was termination, where many tribes lost their status as federally recognized tribes. So President Nixon put an end to the termination era and so said we are going to invest in tribal self-determination and restoration of sovereignty. So when we think about President Nixon, we might not automatically think that he would be an advocate for American Indian people. But actually, when we look at history, he was probably the best president for American Indian policy. And most people don't really know why that is, but I'll let you in on why this happened. But President Nixon was probably the strongest advocate. And he made an executive proclamation in 1970 that started the era of self-determination and ultimately led to the passage of the 1975 Indian Self-Determination and Education Assistance Act. And the reason he was such a strong advocate for American Indians is because of where he went to college. So President Nixon, as a young man, went to college at Whittier College, close to Los Angeles. So Whittier College was a private college, still is, and he played football there. And it just happened to be that his football coach taught political science and philosophy classes, but also was a California native. He was an American Indian from one of the California tribes. So as a young man, Richard Nixon really looked up to his football coach and political science teacher really as a father figure. So as a result, Nixon, in his formative years, as a late teenager and in his early 20s, really became a strong advocate for American Indian causes because of his football coach. So that's why I like to remind people that this is why football is so important. If it wasn't for football, we would not have tribal programs. Isn't that remarkable? So the football coach really had a huge impact on President Nixon, and it changed history in terms of the policies towards self-determination, and particularly in the provision of health services. So I'll make sure that people have a copy of the PowerPoint slides, and there's a link to an article about Richard Nixon's mentor, and he's pictured right here. So this is from his executive proclamation. He states that the time has come to break decisively with the past and to create the conditions for a new era in which the Indian future is determined by Indian acts and Indian decisions. We have turned from the question of whether the federal government has a responsibility to Indians to the question of how that responsibility can best be furthered. We have concluded that the Indians will get better programs and that public monies will be more effectively expended if the people who are most affected by these programs are responsible for operating them. So what wonderful statements, and really setting the tone for a new policy direction. And this had an impact on schools, but also a direct impact on the provision of health services. So the original law had three titles. So a law, so basically Public Law 93-638, what the nomenclature means is it's the 93rd Congress. So this is back in 1975. There was a 638th bill submitted. So Public Law 93-638. And a title is basically like a chapter within the law. Title 1 is Indian Self-Determination. Title 2 is Educational Assistance. And Title 3 was a self-governance demonstration project. So Indian self-determination is the component of the law that allows tribes to contract with the federal government to provide health services rather than IHS, and to provide educational programs rather than the BIA, Bureau of Indian Affairs, or specifically the Bureau of Indian Education. So this law allows the tribes to take over the management of health programs, education programs, and many other programs that historically were operated by the federal government. So that's why we now have a blend of Indian Health Service and tribal health programs. We have a blend of Bureau of Indian Education and tribal schools. We have a blend of BIA police and tribal police. so that the tribes that choose to can take over the management of those programs directly. So this was really an important law, and it provides maximum Indian participation in the government and education of Indian people. So for our purposes, of course, we're looking at this mainly through the lens of healthcare, but it does have a big impact, obviously, on the provision of education programs as well. So this law encourages the development of human resources of Indian people. One way that's done is to also link to additional scholarship programs. It establishes a program of assistance to upgrade Indian education and to support the right of Indian citizens to control their own educational activities. So with this law, tribes can now do some very creative things, like develop cultural immersion programs or language immersion programs as part of their educational systems. So this law really was groundbreaking in allowing for more tribal control of healthcare and education programs. So every law has a declaration of policy kind of at the beginning, kind of an introduction to the law. And in 638, the Declaration of Policy states that Congress recognizes the obligation of the United States to respond to the strong expression of Indian people for self-determination by assuring maximum Indian participation in the direction of educational services, so as to render such services more responsive to the needs and desires of those communities. So again, it's the Indian Self-Determination and Education Assistance Act, and it was written not just with health in mind, but also with educational programs. So this was very important. You might be familiar with the history of boarding schools, and there was unfortunately a time frame with forced boarding school participation. And the way this was done, when tribes were put onto reservations, they lost their food systems and food sovereignty and became dependent on federal programs for food. And what the federal policy was, really from the late 1800s through 1970, in many cases, the federal government would tell the families, either give up your children to go to boarding school, or we will withhold your food rations. So essentially the choice was either give up your children or starve. And as a result, many, many thousands, tens of thousands of American Indian children were placed into boarding schools. And the boarding school system led to all kinds of abuse and trauma that's still being dealt with today. But having the self-determination and education policy within this law really allowed the tribes to start taking over those schools and managing it locally, and then incorporating more opportunities like language immersion. So part of the Declaration of Policy included that Congress declares that a major national goal is to provide the quantity and quality of educational services and opportunities that will permit Indian children to compete and excel, and to achieve the measure of self-determination essential to their social and economic well-being. So we have these great opportunities within 638, but as we'll see, we still have challenges related to health disparities and educational disparities. So thinking about this from the perspective of a health administrator, if you're running a clinic or a hospital, at the end of the fiscal year, and at the federal level, that's October 1. So we're just a couple of weeks into the new fiscal year. So happy new fiscal year for the federal employees out there. But if you have money at the end of the year, that's not good, right? If you don't spend down your funding, your annual budget, you're at risk for losing that unspent money the next year. So at the, in September, there's that spend down period where we want to expend 100% of our budget. Well, that's not a very efficient way to run a health system. And we want to be able to spend funding in a very efficient way, but ideally keep the resources that we don't spend for future use. That's what's done in the private sector, for example. So it's actually written right into the law that any funds for any fiscal year which are not obligated or expended shall remain available for obligation or expenditure during such succeeding fiscal year for which they were originally appropriated, contracted, or granted. No additional justification need be provided by the tribal organization. So what this says is that in the IHS side, in the federal government, if you're not spending all your money, you're at risk for losing that percentage of funding the next fiscal year. but tribes do not run that risk, that if they have money left over in their budget, they get to keep it and use it in future fiscal years. And that's very important when we think about things like trying to prevent diabetes, for example. We cannot think October 1 to October 1. We need to plan for 5, 10, 20 years down the road when we're talking about things like diabetes prevention or cancer prevention. So it does allow more flexibility in programming. So this part of the policy really is an advantage for tribal programs as compared to federal programs. I've heard a lot of pushback from some tribal leaders, particularly here in the Dakotas and to some degree in Montana as well. The thought is that if we 638 or take over the health system, we're kind of letting the federal government off the hook and the absolving of them of their treaty rights. So it's actually stated right in the law, in Title I, Section 111, states that nothing in this act shall be construed as one, affecting, modifying, diminishing, or otherwise impairing the sovereign immunity from suit enjoyed by an Indian tribe as a government, or two, authorizing or requiring the termination of any existing trust responsibility of the United States with respect to the Indian people. So what this states directly in the law is that when a tribe goes through the 638 process and takes over the healthcare system from the IHS, that the federal government still has a trust responsibility to provide health services, and the treaties are still in effect, even if the tribe is managing the health systems. So that's something that I think we need to do a better job of working with our tribal leaders, particularly in the Northern Great Plains, to understand that 638 does not absolve the trust responsibility or the treaty right to health services. So Title III was a self-governance demonstration project, and it was for 18 years. I don't know why they chose 18 years, but that was the determination. So basically 1975 through 1994, 1993, there was a demonstration project, which became known as the Tribal Self-Governance Project. So under Title I of 638, a tribe can contract for the provision of health services. They get the money to provide health services themselves. But it's still the IHS that determines the budget priorities and the line items in the budget. So it's not really self-governance. It's basically managing things as dictated by the IHS. Under self-governance, the funding is seen more like a block grant. So if the overall contract would have been $2 million, in this way, it would be under a compact under Title V. Basically, it's a block grant and the tribe can reprogram those dollars how they see fit. So much more self-governance and much more flexibility. So in 1994, after that demonstration project, that's when Title V started. So these are the self-governance amendments. So there's really two distinct ways in which tribes can assume programs, functions, services, and activities from the Indian Health Service. And you have probably heard of Title I and Title V, right? So Title I contracting, the tribe is basically like any other federal contractor in which they report back to the federal government the deliverables that they've done by managing the health system. Under Title V, it's true self-governance because, again, the money is much more like a block grant that goes to the tribe and they can manage it as they see fit. So we'll talk about how that's being used currently now with Indian Health. So just going over to the last, this is now 17 years ago. Let's look at these numbers. 13 of the hospitals were managed by tribes, so 27%, and 158 health centers or clinics, about 71% of the clinics. So look at that, 13 hospitals and 158 clinics managed by the tribes in 2005. If you go to 2020, we increase the hospitals again, were 13. It's now 51 hospitals, or sorry, 24 hospitals are operated by the IHS and 22 by the tribes. So looking at the health centers, 158 health centers managed by the tribes. That's up to 279. So the vast majority of clinics are managed now by the tribes as compared to the IHS. So this is all under 638 contracts and compacts. In Alaska, 100% of the facilities are operated by the tribes. There are no IHS operated facilities in the state of Alaska. It's all tribally managed. And nationally, if we look at hospitals, it's about half the hospitals are managed by the tribes. And again, the vast majority of clinics are now operated by the tribes. And there's a link in IHS. If you just go to their fact sheets, you can see these data. But each year, there's more and more tribal control of health systems through the federal budget. So looking at our IHS profile, there's tribal members of 574 federally recognized tribes. The IHS serves 2.56 million American Indians and Alaska Natives. The annual patient numbers, over 39,000 admissions and over 13 million outpatient visits. And if we look at the increasing in budget over the last several years, 2014, 4.4 billion, 2017, 5 billion, 2020, 6 billion. And now over 60% of the IHS budget is now managed by tribes through 638 contracts and compacts. So that's why nationally we have this mixture of IHS programs and tribal programs. But in some states like California and Alaska, 100% of the IHS budget is managed by tribes. In states like South Dakota, North Dakota, Montana, we still have a lot of IHS direct services. So it's important to keep this in mind. And when we think about the future of American Indian health policy, my sense is that each year we'll continue to see more and more of the IHS budget managed by the tribal nations. So we did see a big jump over these years, but the president's budget proposal right now, you may have seen this, but he's proposed $9 billion for the IHS in the next fiscal year. Of course, they just passed a continuing resolution. Who knows what's going to happen with the federal budget? Who knows what's going to happen with the midterm elections and things? But it's quite possible we're going to see a significant bump in the IHS budget, which really is necessary. So just thinking, why would a tribe take it over? And, thinking from a health policy perspective, there's a lot of financial advantages to tribal management. I had mentioned carryover funding, that if you are efficient with your dollars, you get to keep those dollars. You don't have to spend it down from, fiscal year to fiscal year. So you can reprogram those dollars to focus on local priorities. Third-party revenue all goes directly to the tribe. The way it works now for IHS is that the service units, the clinics and hospitals generate revenue from Medicare, Medicaid, private insurance, but those dollars go to the area office first and then back out to the tribe that generated it. Under tribal management, you take the area office out of the equation and the tribe gets to collect those dollars directly from third-party revenue. There's also eligibility for grants. So we're all familiar with HRSA, right? Health Resources and Services Administration. In Section 330 of the Public Health Service Act, that's what establishes the community health centers, right? So we have the Bureau of Primary Care under HRSA and the federally qualified health centers. So the IHS is not eligible for the federally qualified health center grants, but tribes are eligible. And it's now around 40 clinics that are 638 clinics, tribally managed, are also community health centers under HRSA. So that's the Section 330 of the Public Health Service Act. So 638 programs are eligible for these grants. IHS is just simply not eligible because a federal agency is not eligible for a grant from another federal agency. But the tribes are. So I've coined a new term. It hasn't taken off yet, but if you're a 638 program and you get a 330 grant, you're now a 968. Hasn't caught on yet, but there's, like I said, about 40 638 sites that also have these community health center grants. And it's really a great advantage from a policy perspective. There's also what's called contract support costs, which are basically your indirect costs. So when you're a contractor, as you know, for those who get contracts or grants, you have your facilities and administrative costs or your indirect costs. And the tribes, in addition to getting the direct funding for managing the health systems, they get indirect money on top of that, and that's called contract support costs. So IHS doesn't get an equivalent extra administrative budget, but tribes do. Then other things, Federal Tort Claims Act liability insurance that carries over to 638 sites. At the state level, there's a Medicaid administrative match fund for administering components of Medicaid. If tribes choose to, they can apply for those Medicaid administrative match dollars. And also, like I had mentioned before, IHS employees cannot lobby, but tribes can. So you can actually become not just the policy maker in terms of 638 and managing the systems, you can also directly lobby Congress as a stakeholder, and just many other financial advantages. So what I've seen, the vast majority of tribes who go through this process wind up increasing their budgets and providing more services. And it's not the fault of IHS, it's just that IHS has limitations in what it can do based on being a federal agency. Tribes have a lot more flexibility. So just in my own experience, I'm again a family doctor, and I've worked in a number of different settings. On the left is Phoenix Indian Medical Center. That's the largest Indian Health Service direct facility. And on the right is Huhuka Memorial Hospital at the Gila River Indian community. And I worked at both places as a primary care doctor. And what I found and this is going back to the 1990s, so a long time ago, but when I was working with IHS, we had to follow the formulary, right? We have a limited set of medications that we can use. And it's very hard to prescribe things that are not in the federal formulary. And then working at the tribal program at Gila River, they had the federal formulary, but they also had an easy process to get non-formulary medications, particularly for things like diabetes. So, I'm the same doctor with the same education, with the same skill sets and knowledge, but my ability to provide healthcare was better under tribal management than federal management, because the tribe could choose to use its excess funding to do things like pay for better medications. It's not a judgment on IHS or a value statement on either way, but as a provider, I could provide higher quality healthcare under a tribally managed program than under a federally managed program. That's my personal experience, and every doctor I've talked to has had the same experience who works in Indian health programs. In many ways, if you're coming right out of residency and you work for IHS, it's almost like stepping back in time because you have less access to newer treatments. And that's just the truth. Again, it's a limitation really based on Congress underfunding IHS. But as a provider, I can provide better healthcare. And it made me very uncomfortable to work in a system that limited the quality of care that I could provide. But that's just the systems in which we work. I think nationally, the best example of an integrated, tribally operated health system is in Alaska. So the Alaska Native Tribal Health Consortium is a nonprofit entity that maximizes its compact with the IHS, but also maximizes a lot of third-party revenue and maximizes grants that they are eligible for. And we have to keep in mind, Alaska is huge. We usually see it on a map kind of in the Pacific Ocean as a relatively small state, but it is huge. The northern tip of Alaska, if that was at the northern tip of Minnesota, the southeastern component of Alaska would go all the way to the coast of Georgia and South Carolina, and the Aleutian Island chain would end in central California. So Alaska is just huge geographically, but they have a really well integrated and organized system that's managed by the tribes. So there are a multitude of tribally operated hospitals, with the hub being Alaska Native Medical Center in Anchorage, Alaska, and then a multitude of tribally operated hospitals throughout the state. Alaska Native Medical Center is just beautiful. If you had a chance to see it, it's just a beautiful facility, and again, managed by the tribes as a 638 facility. So the way it's set up, they have ANMC in Anchorage, Alaska Native Medical Center, tribally operated with inpatient care and multitude of specialty clinics, and then a series of regional hospitals, community hospitals that feed into Anchorage for higher levels of care, and then a multitude of clinics associated with them. And when I see this hub and spoke model, why couldn't we do that in Montana? Why couldn't we do that in the Dakotas? And in truth, we can if we choose to. There's a model in place to do this. It would require a great deal of coordination among tribes. But again, in Montana, there's 8 tribes. In Alaska, there's over 220. and it's a much bigger state. So they were able to do it there. I just think that the future of American Indian health policy includes more coordination with a multitude of tribes. We should be working as networks of providers, not as individually operated systems. So considerations for the future. I am an academic, so I really enjoy health policy research and health services research, but we should be doing more 638 feasibility studies. I just completed one with a tribe in South Dakota and looked at the community readiness assessment as well as the financial feasibility. Also, we need to look at governance structures and tribal partnerships. Again, I think the tribes could work collaboratively to develop really innovative programs like what they do in Alaska. That could be a microcosm of the Alaska system right there in Montana if the tribes chose to go in that direction. Also, tribal state relations are vitally important, particularly with Medicaid and things like the Montana Moms program, right? And with the Montana Department of Public Health and Human Services. The relationship between the tribes and the state is vitally important. And I really do admire what's happening in Montana. I think there's a lot of really good steps that have taken place in the state of Montana. I'm from South Dakota originally, and there's still a strained relationship between the state government and the tribes, even to the extent that the governor threatened to sue a couple of the tribes during COVID-19 for some of their public health provisions. And it's a different world depending on which state you live in. But I think there's some real opportunities in Montana to expand those tribal state relations. And also public-private partnerships. If a tribe becomes a 638 entity and they're providing their own health services, they could become a 501c3. Could a tribe partner with Billings Clinic if they choose to? Sure, they could. These are things that can happen. There's some examples of that in other states where tribes have partnered with private sector entities to provide health services. So that's something that could happen. Obviously, the role of the Affordable Care Act is vitally important. ACA is now 12 years old, if you can believe that, passed in 2010. Medicaid expansion really is a huge piece of that. And as we'll discuss in the next section, looking at poverty, Medicaid and Medicaid expansion is so vitally important. The other challenge we're facing, quite obviously, is just workforce. And whether it's rural or tribal, we just have a huge shortage in our workforce. So we need to work collaboratively to address workforce development. And how could we potentially share providers or use more telemedicine or have more academic medical center partnerships with tribes and Indian Health Service? So you can just see there's a whole host of things that we could look at: best practices, academic partnerships, but also how do we incorporate traditional medicine? And each of those things has a policy basis. So I know it's a lot of information in a relatively short period of time. I actually teach a semester-long course in American Indian health policy, but these are some of the highlights to consider.